we're in week 7. We're over the hump now. So now we're going over the hump week, right? So we're going down the other side. So we had our exam. Grades will be out Saturday morning. If you're having an absolute moment like Tristan was just having, and some other students were like, I don't know, can I breathe? Well, I'll tell you if you can breathe or not. Remember, next week is a quiz. It'll be on this information. And again, talking about that project. Sam did already turn a lot of his project in. I've already looked at it, graded it, sent back comments. So now that he can get that great grade on it. I mean, maybe he didn't get a best grade on something else. So now he's boosted all of those subjective grades up. And I don't blame you at all. If I can get an A, I want an A, on any part of it. So I understand that. So anybody else, just send it in through the modules. There is what we call unlimited submissions, which means I'm going to write in the comment what was wrong. And when you send in the new one, it's going to change. Don't get upset. I know that. I'm giving myself my tally by what I'm writing there too, so that you will get the correct grade you're supposed to. So this week 7, we're going to do cerebral and we're going to do endocrine. And I'm going to do it in a cahoots. Now, cahoots, I think I'm explaining all the concepts. I think I'm explaining it in a manner where we can now relate it to things, just like giving aerosols. What's all the everything? There's always one more step, one more thing to think about. And as we learn, we put those pieces of the pie together. So let's go ahead and just start with the cahoots. We'll do that. Who's going to win today? Julie, you want to win this one too?
I do.
I know you do. I know you're extremely competitive. That's okay. The exam had all the information there, but a lot of it now is taken and applying to the concept. So it was a little trickier. If you knew the information, listen to my cahoots the way I explain things, you're going to be fine with any of your exams. In fact, I always tell you, last
I'll
of
lay
all,
down.
do the cahoots. Excuse me?
Oh, sorry, I was telling my dog to lay down.
Lay down, dog. Here we go. Not a problem.
I didn't realize I had my speaker on. Sorry.
It's okay. Week 7, cerebral and endocrine dysfunction. Remember, this is the quiz for next week. We'll be on this. So, a growth hormone is administered by what route? Now, there are children that are normally short. It's from their family. You can't make them grow more. But there are children who are shorter than they should be. And some of the reasons is that the pituitary gland isn't giving out, all the growth hormone it should. Now, growth hormone takes somebody who needs to be compliant. It's usually a daily injection like insulin. So this person really needs to be compliant, right? They need to take it every day. And what they say about growth hormones is that after you stop growing 1 inch a year is when they stop it because you're not going to get any bigger after that. So growth hormone is a subcutaneous injection, usually daily, and we stop it usually at that adolescent growth spurt time. But we're also going to look at, was the family short and I'm trying to get something that's not going to come because of the familiar history. What's highest priority for a patient diagnosed with syndrome of an inappropriate anti-diuretic hormone? So something's not working right and appropriate. Antidiuretic against urinating hormone. That's how I read these things. And I remember those things. If you're against urinating, something's not right. What are you going to do? That's all about intake output. Also, when we talk about anything with fluid balance, remember it is always daily weights, intake, output. We measure what every visit on a visit from a child, not adults anymore, but children. We always do a height and a weight. That's going to tell us, some things about other things in this in the endocrine area. But when we talk about fluid, it's also intake output. We can look at that. So are they retaining fluid or not? Which of the following are signs and symptoms of an inappropriate antidiuretic hormone? Antidiuretic means what? Against urinating. What would you see? Very simple. That's a big word that drives students nuts. I just broke it down and made it very easy for you. So it's simply anti-urinating, against urinating, decreased urine output. It's nothing to do with specific gravity. It has nothing to do, it has everything to do with decreased urine, not increased. What is important to cover when teaching the family about propylocuracil, which is PTU? It's a hormone for thyroid, hyperthyroidism. And this is a medicine that we have to watch out for side effects. So it's against, it blocks the hormone of thyroid not to secrete so much because it already has too much hormone in the body. The side effect is leukopenia. I mean, many of these drugs, and any drug that had a problem with a drug fever, I always got it. Clindamycin, the clindamycin was the big one with me, where an antibiotic causes fever or sore throat. Well, it's the same thing with this thing, the propylocuracil, PTU. It's also risk for fever, sore throat. So we teach our family this. If they get a fever or sore throat, we'll go to the doctor and be checked. Is it the drug causing it? Or is it true and real? I'm getting sick. Okay. And it will make a difference. Do you continue the drug? You're actually having a reaction to it. A multi. An initial sign of diabetes insipidus. I don't know if you've gone over it yet in your med surge, but diabetes insipidus has to do with the posterior pituitary gland. And this has everything to do with fluid balance and nothing to do with blood sugars. Why they put the word diabetes there, I don't know. It's to confuse us, isn't it? Right? We know that diabetes insipidus is only two P's. It is urinating a lot, drinking a lot. And you could stop giving them fluid and they're still going to be urinating. Now, when we talk about diabetes insipidus, it's the three P's. So add on, I'm hungry too. Why would you be hungry with diabetes mellitus? Well, your body's not absorbing sugar and the body's hungry. So what does the body do when it's hungry? It says eat. So you're going to see them eating a lot, drinking a lot, urinating a lot. It's all three P's. That's how I remember both of them. Multi. What are the clinical manifestations of juvenile hypothyroidism? And you're talking children, you could be born congenitally with it. And this is one that initially at birth, this child's not going to move a meconium stool, meconium ileus, it's called. Hypothyroidism is one of them that causes you not to have your stool right away, and it might be checked for it. All the signs and symptoms after that are all the same with adults, except thyroid hormone is extremely important in children for growth. Okay. You need to have it to be able to grow and remember cognition. So, thyroid, cognition, growth, that's your children. And then, just like adults, dry skin, constipation, cold intolerance, all of that is thyroidism in adult children, don't matter. Remember, kids is all about growth and cognition with thyroids. A child has a simple seizure. What education would you provide to the parents? So, a simple febrile seizure, probably the most common of seizures. And what happens is you have a child who has no fever. And in 20 minutes later, they're 101, 102. So it's how quickly it got up to be a fever that says, brain, I don't understand. It sparks and they have a seizure. That's how I explain it. So a seizure is a seizure, whether it's febrile or if it's due to, other things, just having the grand mal tonic-clonics due to something with the brain. It's always safety, 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 safety. So what do we do with a seizure? Turn them over to the side. Have suction at the bedside. If they vomit on their side, you don't want them to inhale it, right? Make sure there's no sharps in the bed. If you walk in, see beds side rails down, pull them up, pat them if you can. All right. So keep the airway open, safety, clear the area from anything sharp, toys in the bed. They love that, because they're going to be, moving with it also. Okay. So safety, safety. What type of seizure is it when the body's jerking, foaming in the mouth, and rendered unconscious? And that's the post-ictal afterwards, too. When you think of seizures, this is what you think of. You don't think of absent seizures, which are very difficult to detect. But it's tonic-clonic. That's grand mal. That's the old name for it. Some books still have grand mal, and some have changed to the tonic-clonic. The name to be used is tonic-clonic. What's an absent fever seizure? This is when a child, adult, looks at you, but they're not, comprehending. They're like a blank stare. It could be as simple as that. Absent seizure. So that's a very difficult one to be able to diagnose. Okay. It'd be somebody who knew you well, like you're trying to call their name and they're not answering. That's what you would say. What notable sign may indicate increased intracranial pressure on an infant? So when we think of increased intracranial pressure in an infant, we usually think of hydrocephalus. I mean, yes, it could be due to a fall. Absolutely. But intracranial pressure, we sort of think of the cerebral spinal fluid. So when we see the fluid pushing out, you're going to see this cry that is an octave higher and sharp. You could walk into a nursery full of babies, and one will be a kid who has a neurological something going on, and you will know the difference. It is that distinctive. Also, they have these nice vessels right in front of their ears, behind their ears. They will pop up. They call it bulging scalp veins. So high pitched crying and that bulging scalp veins, not a fontanelle. Fontanelle, would we see when crying? Well, we'd see it all the time, right? If it's increased, it's all the time. All of the following increase intracranial pressure, except and understanding this is when we're taking care of a child with traumatic, have some sort of traumatic brain injury or concussion or a brain surgery. These are things we need to know what to avoid to increase pressure. So all of them increase it, except, it doesn't matter your heart rate. Heart rate up, down doesn't matter. Too much fluid goes right to the brain and it swells, and that's going to increase pressure more. coughing bearing down, constipation bearing down. We tried to not get our children and adults constipated because we want it to flow easier. And of course, anything that gags the throat, which is suctioning also. What findings can alert you to a head injury getting worse? She had a child who was on the second floor balcony, decided to climb on the table and look over and fell down. Head injury. I've seen that. Everything about a head injury getting worse, it's all about swelling in the brain, pressing there, and that causes change in orientation. Other things that you would see. A headache getting worse could even wake them up from a sleep, right? Vomiting, which has no correlation to food and when you ate, it just vomits whenever and getting worse as it goes on. But the big one, change in orientation, your LOC changes. You're going to be more drowsy. Select. What does it mean when you see a fixed and dilated pupil after a head injury? You know, one of the things as medical professionals that you do when you get a patient in, adult, children, doesn't matter, they've fallen down, they've hit their head pretty hard. First thing we do to see what outcomes will be by opening the eyes and looking at their pupils. Is it dilated? Is it constricted? Is it responding to light? Okay. So, what happens when that pupil's very dilated? Well, it is telling you the brain stem is damaged. Well, what's in the brain stem? It's your all your vital signs, it's your heart rate, it's your blood pressure, right? So you're not getting what you need, and it's going to end up with permanent brain damage because we didn't get the blood flow back to the brain stem where it needs because of all of that pressure that's built up after the head injury. Okay. What medication may be used for a child with cerebral edema due to a fall? Well, what medication do you use for anything in the brain that's swelling? So we know edema has to be diuretic, but it's not the normal everyday one. It's not furosemide. It is mannitol. Because remember, the swelling could go to the posterior pituitary and it could cause it to secrete more anti-diuretic hormone, right? So you're not urinating. You give mannitol specific to it, it will let that fluid come out and it will prevent head injury and brain damage going further. Ray's syndrome. We cover this a couple times in class. It's in a couple different chapters. In Ray's syndrome, it's caused by aspirin, and a metabolic disorder occurs in children. And the other part of it is following a viral illness. So, viral meningitis, yes. Bacterial meningitis, no. Okay. So, usually it's influenza. That's the big one. It usually follows. So, that would put you on alert. And of course, teaching parents, unless you have Kawasaki disease, don't ever take aspirin, right? Febrile seizures usually occur in of all my grandchildren, my first grandson had a febrile seizure and he was about 9 months old. Well, forever and ever, my daughter in law, carries a thermometer in her purse. The child is 11 years old now, so he's really outgrown it. But she always is taking that temperature because it's very scary. It's a tonic clonic. And usually the febrile seizures, like happened with her, was at night, when he was in his bed alone. So it was hearing something going on that they went in. So 6 months to 6 years, they usually outgrow it. And my grandson did. Childhood hypopituitarism results in which condition? We have an anterior and we have a posterior pituitary, right? So pituitarism. The posterior pituitary talks about fluid balance, too much, too little. Now, the other side has to do with growth, whether it's needing growth hormone or there is a condition, dwarfism, or too much gigantism. Some of these children become 8-foot adults because of just the pituitary gland. The anterior lobe is giving them too much hormone and growing too much. How would you describe precocious puberty? We talk precocious puberty and we're talking things like steroids and adrenal hormones in the body. And precocious puberty is one of those conditions where you reach puberty very early. But what and how would you know that? Well, at puberty, women, first thing that happens is they develop breast buds, right? So a little girl, you might see it through their shirts. We might see it. Little boys is harder because it's testicular enlargement, but you would see those things in this early puberty or precocious puberty. There is something, and we don't test on the name that was part of pharmacology, but it's Lupron. And we give it until that point where puberty should start. Usually, and actually, it's 12 years, 5 months, according to some of the textbooks, okay? Multi-select. What lab values are important to monitor with a child with congenital hypothyroidism? So they were born with not enough thyroid hormone. They either knew because the parents had tested it, or the baby was born and didn't move their bowels. So they tested their thyroid levels, which are T3, T4, TSH. That's all we have to do with thyroid, okay? When you talk growth hormone, you're talking about that pituitary, the anterior pituitary gland. And cortisol is adrenal glands, okay? You got to sort of figure out where does it come from? And then you can figure out what you look for, and how to treat it. What are symptoms of it? How can you monitor a child that has hypo or hyperthyroidism? What did I tell you, children, the difference between children and adults are in thyroid? Well, we know they have dry skin, constipation, cold intolerance. But remember, children are also about growth. And we do that every time they come to see us. Even in the ER, even in critical situations, we're going to get the best height and weight we can. So height and weights are very important. Monitoring children, not only to see if they're in that percentile, but if they have any other condition that's stopping their growth or increasing their growth too much, okay? What acid-base alteration would you see in a diabetic child with Kussmaul respirations? Remember, Kussmaul is slow and forceful contractions. We know it is a respiratory alkalosis that's trying to compensate for the body has gone into metabolic acidosis, right? So Kussmaul is all about the lungs trying to compensate respiratory alkalosis. And we know that diabetics get very acidotic with all the ketones. Their pHs go real low, with these blood sugars. So it's there to try to help compensate that metabolic acidosis. A multi. What would a child with Cushing syndrome look like? Now, usually Cushing syndrome is due, but because we gave steroids to the child. maybe too much, too long is usually. And remember, these are children that look like they've gained a lot of weight. Big, round moon face, little hairs on the chinny chins, even young children. Those big red, that ruddy is those like demarcated redness in the cheeks, okay? And then all extra weight in the trunk and the face. So you're going to see all this big type of like pudgy looking fat. So, how do we treat Cushing's syndrome? Well, it's usually due to we giving them too much steroids. Well, we'll never just stop steroids because you're going to go into a crisis, adrenal crisis, and we don't want to. Because remember, Cushing is steroids, is adrenal gland, okay? So, this is something we would taper off really slow, or we will have that adrenal crisis and high blood pressure, and it'll be a point to a code situation if we don't take care of it and we treat it with a steroid. You walk into a child's room, they have a fever of 104.6, you see them having a seizure. What can you do? What are you going to do for that child? So remember, seizures, fevers, safety, what do? Right? Always think seizures, always think safety. Check the bed, turn them to the side rails up, and we don't do shock them with any cold water, nothing. That was years ago. No, we don't do that. It's not good for them, actually. An autoimmune disease of the thyroid gland. This is usually girls, late school age, early adolescence, we find it. It's usually you'll see like some sort of enlarged looking area around the thyroid. And it is autoimmune. How do we treat it? Well, there's a problem with thyroid hormones. So we treat them with usually two different types of thyroid hormone, and we monitor them regularly. Because remember, Hashimoto's is not enough of this usually. And what we have to do is make sure that they get the hormone they need for growth, height, and for their brains again, cognition. It's all part of it. Addison disease. Can you say opposite of Cushing's? Again, adrenal. You need to know the names of diseases and where it comes from. What is adrenal all about? Well, adrenal gland is all about steroids, whether endogenous or we've taken it. So, Addison disease, we actually see this when there's ambiguous genitalia. We don't know boy or girl. Sex hormones aren't delivered correctly. So, these children for life will be on cortisol and aldosterone. And we also know that with that, they're also going to be getting extra doses when stressed. Again, autoimmune stress affects them absolutely. So Addison is too little, Cushing's is too much. A ventricular peritoneal shunt. Now, this is all to do with the brain. You can see a tube that's there in the fourth ventricle, actually. And this is where the body's brain and spinal cord is not moving the cerebral spinal fluid around the way it should. And because it gets stuck in the brain, literally, it causes hydrocephalus. Again, remember, this is pressure in the brain. We're worried about, body functionings, etc. This shunt goes behind in the brain, behind the ear, comes out in front of the chest, and it goes into the peritoneum or the peritoneal cavity. We do not touch the shunt. And there is a little pump looking thing behind the ear. Only neurosurgeons do that. So, how do we assess the VP shunt? Well, we're going to be measuring their heads and their abdomens. We can too, looking, are there any big increases in those sort of things? Also, we're going to looking at their cognition. Are they alert the way they should, right? Too much pressure, they're not going to have that alertness the way they should. A common sign of Graves' disease includes blank or protrusion of eyes. So we have hypothyroidism, and then the opposite, too much thyroid, is Graves' disease. How do we treat Graves' disease? Too much thyroid hormone. Well, one of the big things that clue a healthcare provider is you see these big eyes, just like that picture. I had a girlfriend whose eyes looked like that, but she wasn't thyroid. It was just her nationality, and that was common in her family. I was like, okay. Because many people like, do you have thyroid disease? She's like, I'm tired of them asking me that. Because no, I don't. So high thyroid, you want to block the hormone so it's not so much, going to be produced, right? That PTU would be one of them that we would give. This is something that we could, if needed, take out that thyroid, right? On the immune problem, Hashimoto, we cannot remove that um, thyroid, okay? But in Graves' disease, that is one of the options. Taking out the thyroid to decrease the amount of hormone being delivered, and then they would be on replacements for the rest of their life. Die. Hypoparathyroidism has the symptoms of technic muscle contractions and blank. So hypoparathyroid and hypothyroidism are apples and oranges. They're not the same. We know that the thyroid regulates the thyroid hormone, but the parathyroid is all about calcium. Calcium has to do with muscle contractions. Too much, they'd be tetanic, and too little, they would be weak. All right. And of course, you would, if you measure their calcium levels, it would be very low on hypoparathyroidism. So, parathyroid, calcium. A multi. What are signs of hyperparathyroidism? And all the others are hypo. So you would be nauseous, vomiting, confused. Those calcium levels are high. There's paresthesia. They're so tense, you can't even move them. You can't even really feel them. And of course, it's hypercalciuminemia. What does the parathyroid hormone do? Simply, so the parathyroid is all about calcium levels, regulating too much, too little, it figures it out. The urinary output, what is that? That is your pituitary, posterior pituitary gland. Growth hormones or your cortisols. Growth hormones are your anterior pituitary. And then your sex assignment is going to be your adrenal gland, and that has to do with not enough cortisol in the body, cortisol or aldosterone. Which of the following might be a cause of an adrenal crisis or an Addisonian crisis? Did I say? I actually mentioned it. Addison's disease is what? Too much steroids. So, what would be a cause when you have that? Well, you took the steroids away too quickly, and it is that abrupt. Very good. You knew that one. Select again. The cardinal sign of diabetes insipidus is what? So remember, are there three P's or are there two P's? So it is two P's. Great job. You're thirsty and you're urinating. When it gets to be diabetes mellitus, then it comes, I'm hungry, because your body's not eating sugar and the body's hungry. A multi. Congenital hypoplasia parent teaching should include. So congenital hypoplasia, this is adrenal glands, okay? So it's not enough. What adrenal hormones are being secreted? So they're not getting the adrenal stuff. They're not getting their aldosterone. They're not getting their cortisol. These children are actually born with ambiguous genitalia. My career, I've only seen one. And I was like, oh, so what do we do now? And it was very early in going into the newborn on intensive care unit. This child had a vagina and testicles and a prominent clitoris. So it looked like a boy at first look, but what is it really? That's something that you have to go back, and look at. Causes type 1 diabetes. So, type 1 diabetes is that your pancreas, those beta cells are not working right. Your body is attacking it and doesn't like it. So, you don't have what you need to produce pancreas, right? It's nothing to do with anything else. It's just your body doesn't have what it needs and it will forever need insulin. You don't go from type 1 to type 2 if you're good. Nope. If you're type 1, you'll always be type 1. What statement about a pheochromocytoma is correct? Now, pheochromocytoma is usually off the adrenal gland. It is a tumor. And the adrenal glands also have a sympathetic sort of reaction, as in they produce catecholamines. Well, what does that mean? What it means is if you have a pheochromocytoma, sometimes the way you move or you rub, it creates the adrenal gland to produce, this catecholamine, and it's released. So you would see everything up, sympathetic, catecholamine up, 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 heart rate up, blood pressure up, tightness in chest, maybe even dizziness. So pheochromocytoma, very difficult to diagnose. And what they do is they have to find it first. Now, I think it's a heart because you're complaining of intermittent elevated heart rate. But then you find out, no, it's your adrenal gland. And they do actually do surgery and take it out once they find it. A multi. What action should the nurse implement in the care of a patient with pheochromocytoma? So, you as a nurse, you're going to go in and assess this patient. What do you need to go and look at? Right? As simple as that. Pheochromocytoma. What are my concerns? What might I see? How do I look at that? So again, it's the vital signs. Has nothing to do with glucose. This is the adrenal gland, okay? Nothing to do with blood sugars. And it's not the pituitary gland, has nothing to do with fluid balance. So what's left? You have a catecholamine producing tumor. It will squirt out these catecholamines, which will increase heart rate and increase blood pressure. So this child or this adult's complaining of tight chest, oh, my heart rate's up. What are you going to do? You're going to do a set of vital signs, okay? And then you, of course, tell the physician you saw it. A multi. Nursing care of an unconscious child include what? Many times we think children are resilient and don't need all the things that maybe an elderly adult does. No, unconscious child, unconscious adult, we're still going to be treating them all the same way. We're going to be doing the vital signs. Pain control, that's one of those maybe, maybe not. At least something for sedation, because usually unconscious means they're intubated also. So you want them comfortable with that tube. Of course, intake output, unconscious brain. You don't want fluid overload to the brain. What might you suspect if a child feels jittery, sweating, and is dizzy? So this is probably hypoglycemia. Doesn't matter, adult, child, it's the same feelings. Adults can express it better. Symptoms of diabetic ketoacidosis are, and when this is done, I'm going to tell you DKA quickly. DKA is diabetes where the pancreas, it's immunosuppressed and it doesn't produce what you need in order to digest fats and sugars in the body, right? It's part of it. So what happens is the body says, I'm hungry and sugars aren't working here. So I need to find something else to eat today. So they look at your proteins and they look at your fats as a substitute for it, right? What are the byproducts of these digestions? Ketones. Now, without insulin, blood sugars are still going to be off the roof. The highest one I've seen was 1102. And this child had a pH of 6.88. And the kid made it. The kid did fine. I don't know how. That probably was the highest levels I've seen with it. So, how do we treat DKA? Well, first, let's dilate all of that, dilute that blood sugar in there. Let's give some fluids and let's give some regular insulin IV. We want it to work quick, get that blood sugar down. Okay. So, with these elevated blood sugars, it is like if you have a child or an adult with DKA, you walk into their room and you're going to be hit with a smell that smells like a rotten peach that's been placed in a Tupperware container in the refrigerator for a month. So it's now sweet and rotten. Open that up, and that smells just like a DKA patient. It's that they're just oozing sugar out of their pores, basically. So that's DKA. A multi. An adolescent with a BMI above 95%. They've been urinating a lot. What tests can you anticipate that this doctor is going to order? So BMI is very high. We know that's obese, right? 85% is overweight, 95 would be obese. Urinating a lot. What could that be? Well, it could be a simple urinary tract infection. Oh, it could be your blood sugar, right? So this is diabetes. So that hemoglobin A1C measures the last couple months of that blood sugar. And pregnancy, no, not really. Do you see it more? But electrolytes, if they're urinating a lot, the potassium, electrolytes, some of them are going to be decreased. Very good. DKA is caused by what? Body said, I'm hungry. You're not giving me what I need, and I'm hungry. So you don't have insulin. You're not digesting carbohydrates and sugars. Your body is like, hello, I'm hungry here. I need something. So they go to the protein, they go to the fats, and they use that for fuels. But that will end up with them digesting, causing ketones, causing acidosis, and causing ketosis. Okay. multi. A child's admitted with a blood sugar greater than 600 and large ketones in the urine. Your priority intervention. What do you want first? What's your priority treatment? You've already done a blood sugar and you've dipped the urine. You've got all the information you need. What's your order going to be? Number one, priority. Number one is IV normal saline bolus. Why? We want to dilute that high blood sugar. The body don't like it that high. The organs don't like it that high. And of course, they'll be placed on regular insulin drip. Nothing is going to be sub-Q here. And the only insulin we can give IV is regular, okay? After that, you'll start worried about things like your electrolytes. A diabetic child complains of feeling jittery. The blood sugar is 45. What's the best treatment for this child? Well, what is a normal blood sugar for a child? They say 100. 109, I believe, is the number. So if this child has a blood sugar of 45, they're complaining. So they're alert. That was the key word here. So nothing's going to be, anything by IM injection, anything. They can drink orange juice, milk, but remember, they're going to be needing some high source of carb proteins like a turkey sandwich because that maintains your blood sugar. That orange juice will go away quickly. So make sure they get something to eat. Your patients experienced a head injury. What would most concern you? Head injury, concern, worried about all the swelling in the brain because of the injury, right? What can happen during that time? Pressing on the posterior pituitary, and now we have that anti-diuretic hormone's been triggered, and now you're decreasing your output and now increasing pressure in your head. Good job. That was good. A multi. How do you detect diabetes ketoacidosis? So elevated blood sugars, ketones present, and then 4+ glucose in the urine. Most of these kids actually are dehydrated only because of the concentration of sugar, but it's not really a dehydration. I'm glad you didn't choose it. A multi. What would alert you that a child's head injury is deteriorating? So I said with head injuries, swelling's coming up. And what would you see? They'd be getting more confused, difficult to arouse, obtunded if you let it go that far. And of course, headache getting worse or vomiting, non-related to eating, which gets worse. All of those get worse. And the level of consciousness getting worse. Those three things. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? Bacterial meningitis. The brain is infected, has an infection in there, a bacteria. We're worried about the brain and the meninges, all of that. So we're going to be monitoring antibiotics. We want to stop that infection, that inflammation going on. Once you gave a dose of antibiotic, In 24 hours, that child does not have to be on any droplet isolation anymore. So that's why priority, let's give that antibiotic. Yes, we're going to monitor INO. Maybe the head of the bed elevated like that. They have a headache, they might get pain med. Priority, antibiotics. It's the primary cause of injury associated with submersion, drowning. This also could go for smoke inhalation. Your lungs have something in there that shouldn't have been there, right? So the big thing is the fluid, the whatever, the lake, the pool, all the water got in there and you had an hypoxic episode. That's the primary cause there. Not pneumonia, it's hypoxia, which was caused by the pneumonia of fluid in there, if you want to put it that way. And last question, a multi. The CSF, which CSF lab results correlate with bacterial meningitis diagnosis? You get children and adults and complaining of all the symptoms, nuchal rigidity, they're picking their knees up when you hit their head up, the light problems, pain, all of that. Now, we're going to do a lumbar puncture, guaranteed. When would I know? Well, first of all, I would know when it's not clear. If it's clear, it's a virus. If it's white, that's showing you white blood cells in there. So, bacterial meningitis, that bacteria loves sugar. So, your glucose levels are low, but it doesn't like protein, so those levels are high. So bacterial meningitis, sugars are low in the cerebral spinal fluid, and the protein levels are high. That's when you know, yes, this is bacterial. Where's that antibiotic? Let me start it right now. Amber, good job, Amber. Number two, Elisa, good job. And Julie, did you do it? Julie, good job, Julie. I know you work hard for that. Chelsea and Britt. So I know a lot of you are biting at the bit, wants to know your grades. Can't give you a grade. I know that it would be easier if I could, but my boss will not be happy with me. And if you want me to stay around and be a teacher, she does check on those sort of things. I can tell you up or down, or I can do one of these, means you're there. But that's all I can tell you. Any questions, anything else you need to know? Remember, I need those names of those diagnoses. Remember, next week is week 8. So you've got all this week to start working on it. Give it to me so that I can help you with it. Because I know you also have community in there also. So you're busy. Thank you guys.
Uh,
Yes, Sam, I know.
okay.
Nobody wants to leave. They all want their grades. I can't.
You could just give me a thumbs up or a thumbs down or a,
You need one of those?
I mean,
Hold
I would
on.
prefer a thumbs up, but yeah.
Oh, you don't want just one of them?
I just, you know,
You don't care if everybody sees?
I don't care.
There you
Okay.
go.
I'd like one too.
You all are getting me.